Thank you so much for your kind introduction. Madam has done my job easier by giving you a very short lecture. And before you all came, we were having talk about anemia. When we were students 45 years back, the same situation we had. And we are talking about eradicating anemia and all that. I think it is nonsense, absolute nonsense. Politicians are good at giving you all these things that eradicate tuberculosis, eradicate cataract and all. It's not going to happen. Unfortunately, anemia, we have not put a dent also. I am not here to teach you how to manage anemia, first of all. Basically, I'm going to talk to you on a new molecule that has come in the market, and I'm sure few of you must be using it in your practice. And that molecule is I3, injection I3. What is this I3? There are three I's. First I is intravenous, second I is iron, and third I is the molecule isomaltoside, injection I3. I hope it's very easy to remember. We will not go into all these details of classification of anemia. This is not a PG class. Although I have all these things because I have used it to cover even residents when I don't see a single resident here. They're all practicing gynecologists right now. What is iron deficiency anemia? It's the most common type of anemia, and it occurs when body doesn't have enough of iron needed to make hemoglobin, and we all know what are the symptoms of iron deficiency anemia. You look at this, Canada has 3% incidence of anemia, and look at the bottom, India has almost 40%. And I have spent my whole life, I have spent my whole life as a teaching faculty at KEM Hospital and Sion Hospital, Mumbai, 34 years. And we used to have 2/3 of pregnant patients coming with anemia. 2/3. Something very shocking. And it has not changed, I'm sorry to say this. And we are responsible, we the gynecologists. We can't blame anyone else. According to 5th National Family Health Survey, conducted in 2020, children below the age of 5 years depend on mothers for iron needs and it's neglected in India. Their deaths up to 5 years are indirectly related to anemia. NFHS 5 says that anemia cases in India are on the rise. This is a recent National Family Health Survey, covers 6.1 lakh samples. 67.5% of Indian children aged 6 to 60 months almost were found to be anemic. Now look at the last line. The iron deficiency in pregnancy is responsible to percolate this condition down to the children. It's not only mother and what madam said about the complications. It goes to the next generation to whom she is going to give birth. We all know about this. This theoretical part I am not going to discuss. The causes of IDA, physiological reduced intake, GI blood loss, genitourinary blood loss, intraventricular hemolytic anemia, malabsorption, developing countries, genetic, drugs, miscellaneous. But why do we have such a high prevalence in our country? Number one is poor eating habits, inadequate dietary intake of iron and defective iron absorption, early onset childbearing, higher parity, short interpregnancy interval, excess physiological blood loss during adolescence and pregnancy, hookworm infestation, and lack of access to health care. Now, I was talking to Madam Sharda Jain, and she said that unless we have a higher goals, higher aim, we will not reach what is normal. Now, we all want to operate on our patients, am I right? And for any operation, we need anesthesia fitness. So what is the hemoglobin required for anesthesia fitness? Isn't it unfortunate? I don't know who has brought this. I know, yeah, but unfortunately, even today, the anesthetists, they will make the patient fit if the hemoglobin is more than 10. Actually, 10 to 10.9 is mild anemia. 10 to 10.9 is mild anemia. Please remember this and keep it in your mind. Minimum level of hemoglobin that you should have for your patient, gynec or obstetric, should be 11. Minimum. 12, fair enough. No, at least aim at 12, you will at least achieve something around 11. Go for a higher aim. 7 to 10 is moderate anemia, and less than 7, as madam has already said, severe anemia. So one thing you will go back in your minds today is normal hemoglobin is more than 11 grams per cent. This has already been told to you about outcome of iron deficiency anemia in pregnancy. Maternal morbidity, mortality is increased. Effect on the fetus, decreased weight on delivery, greater risk of anemia after birth, long-term deficit in physical and mental health, and effect on pregnancy outcome, preterm low birth weight, etc., etc. Lancet 2018 confirms from an international study of over 3 lakh women across 29 countries, including India, that pregnant women with anemia are twice likely to die during or shortly after pregnancy compared to those without anemia. Now, such a fantastic thing has been given to you. Still, we don't take it seriously. This is very unfortunate. We're looking at somebody's life. And this sentence, please keep it in your mind, that the mortality can go up. The proper and timely management of IDA, especially in pregnancy, is very necessary. We all know how to diagnose: history, examination, and investigation. Now, there are lots of recommendations, and basically screening recommendations. The CDC recommends both universal screening for iron deficiency anemia in pregnant women and universal iron supplementation. Universal iron supplementation. Recommended daily dietary allowance is 27 milligram per day during pregnancy and 9 milligram per day during lactation. The typical diet only confers approximately 15 milligram of daily iron. Now remember this. What is required and what the best possible diet can give you, there is a deficit. Even if you come from the highest possible strata of our society, you are deficient in your iron intake. That is the reason we have to give iron to all the pregnant ladies, irrespective of whether she is coming from poor class, middle class, or the highest possible class in our country. I hope it is clear. There is a deficit. CDC recommends screening of iron deficiency anemia and CBC twice in pregnancy, first time in first trimester or whenever she comes to you for the first time, and again between 24 to 28 weeks. And the initial evaluation includes not only hemoglobin, like what we do all these years we have been doing in our teaching hospitals, only hemoglobin, blood group, VDRL, HIV, RBC indices, serum iron levels, and ferritin. Now I want to ask a question to the elite group of ladies sitting here. How many of you ask for ferritin level in a case of iron deficiency anemia? Please raise hands. I'm very happy that at least 50% of the gynecologists in Delhi ask for ferritin. I'll tell you one simple reason for it. If ferritin is abnormal, less, it indirectly tells you that there is iron deficiency. Indirectly. And that you have to replenish the depleted iron stores. Unless the iron stores are depleted, a woman's hemoglobin is not going to come down. Please remember this very clearly. Ferritin. Okay? Second thing which you will now keep in mind when you go home is to ask for ferritin levels and indices, not only hemoglobin, when you have the possibility of iron deficiency anemia. Expect reticulocytosis in 7 to 10 days and subsequent improvement in hemoglobin and hematocrit afterwards once you have started hemoglobin. So, hemoglobin estimation, when do you call IDA? Hemoglobin less than 11, low level of ferritin less than 30 microgram per liter is evidence of depleted iron stores. Low serum iron, all of us know less than 60 milligram per deciliter. Elevated total iron binding capacity, microcytic anemia with MCV less than 80, and anemia seen on CBC, the peripheral smear, all those things we know. We don't do this EPP. We don't do raised serum transferrin receptor. But yes, blood indices are a must. And even if after giving treatment, whatever, if the hemoglobin doesn't improve, and if you ruled out hemoglobinopathies, then bone marrow biopsy. Now coming to management, again all of you know very well, it's divided into medical nutrition therapy, deworming, oral iron, parenteral iron, and blood transfusion depending on the severity. Choice of correct treatment of anemia depends on severity of anemia, gestational age of pregnancy, and tolerance of therapy chosen. Poonam, welcome. Coming to medical nutrition therapy. Thank you. Consumption of iron-rich foods, and let me tell you, you must have by heart what are the iron-rich food preparations. You can't give her one or two options. You must know all the iron-rich food preparations. And you must tell her that these are the options you can take. Cooking food in iron utensils. In Mumbai, when we were in schools, pav bhaji came. Pav bhaji for the first time. And there is a huge iron tawa on which they used to keep rubbing it. I am not giving you any hint, by the way. But that is the way you can make food iron rich. Sorry to say this, but this was happening in Mumbai many years back when we were school students. Then, but this India has something unique, whereby at least you get iron in a different way. Intake of heme iron, adding iron absorption enhancer like ascorbic acid, vitamin C, compounds in diet. Avoid, now remember this again, tea, coffee, phytates, along with iron supplements. And ideally, the intake of iron should be in between meals. Does it happen? It does not happen. Now, all these words which I have brought, they are very important. We don't have time, busy practice. There are many patients waiting in the OPD, and you don't have time to counsel the patient properly. You can have something written down and given it to her if she is iron deficiency anemia. She can read it at home if you don't have time to talk to her. Your assistant can do it, but all these things are very important, equally important as iron compounds. So, During pregnancy, around 40 milligram per day, lactation 23 milligram. This is by ICMR, so you must accept it, and National Institute of Nutrition. Ideally, women should enter pregnancy with adequate stores. Ideally, means what? Ferritin level should be more than 30 microgram per liter. Ideally. Okay. As a public health approach, prolonged oral iron supplementation even before pregnancy is a better strategy. Preconception counseling. Government of India and Ministry of Health and Family Welfare recommend 60 milligram of elemental iron with 0.5 milligram of folic acid from second trimester. Don't give it in first trimester. Continued throughout the pregnancy, minimum 180 days during pregnancy, and to be continued for 180 days postpartum. Now, I'm going to ask you a question. Many of you have delivered children. When you were pregnant, how many of you used to take iron supplement religiously without forgetting a single day for 180 days and even after delivery for 6 months? I don't expect a single hand to be raised. Am I right? See, once delivery is over, everybody forgets everything. Patient doesn't come back to you unless she has to come for suture removal or her baby has some problem. She'll come to you. She will not come back to you otherwise. This is a very sad situation. We as gynecologists also do not follow this. I was talking to madam that even if 7 days course of antibiotics has to be taken by us, how many times do we forget? Just think of it, 360 days of iron, black stools. This is what government wants us to propagate and use in our practice. We all know what are the problems of oral iron: metallic taste, nausea, vomiting, heartburn, epigastric pain, constipation, diarrhea, etc. I don't know, I'm going back. Okay. Deworming has been told to you by Dr. Shraddha Jain. Albendazole 400 milligrams stat or mebendazole 500 milligrams stat or 100 milligram twice a day for 3 days. Don't mix up. Don't mix up. We were given this Anemia Mukt Bharat in 2018. I can assure you anemia has gone up. Government people give you these slogans, but in reality, on the grounds, nothing happens. Nothing happens. So, according to government, give it in second trimester. Don't give it in first trimester. Albendazole 400 milligrams stat to all antenatal patients. To all antenatal patients. Oral iron represents first line of therapy for iron deficiency anemia, but only 1 to 8% of iron is absorbed from available oral iron preparations. Absorption increases with increasing doses of oral iron only up to 160 milligram per day. Don't keep giving more and more iron. She will not be able to tolerate. And obviously, if she is iron deficient, the absorption increases. We all know the different oral iron preparations. Whatever you have been using in your practice, continue to use that. I am not going to tell you which one is better, which one is not. What are the instructions? Tablet to be taken on empty stomach, ideally. Or at least, this is more important, 1 hour after a meal, in case she gets nausea, vomiting, or gastritis, for better absorption. I hope it is very clear. 1 hour after meal. Avoid consumption of tea, coffee, milk, calcium tablets. Take vitamin C and start with low dose to decrease the side effects. The factors that affect the oral iron absorption include the dose that you give, status of the patient's iron stores, the form that is administered, stability in gastric acid, elemental iron, and bioavailability. Now, oral iron therapy recommendation for prophylaxis includes daily 60 milligram plus 400 microgram of folic acid till term by WHO. For treatment, according to WHO, 120 milligram of iron plus 400 microgram of folic acid till term, and in postpartum 60 milligram of iron plus 400 microgram folic acid for 3 months. We have to follow the Ministry of Health and Family Welfare, Government of India, 100 milligram of iron, 500 microgram of folic acid for 100 days starting after first trimester around 14th week. And for treatment, if it is mild anemia, 2 iron folic acid tablets per day for 100 days. And if it is moderate anemia, straightway parenteral iron. Please remember this. Intramuscular iron is banned. Is banned. If anyone is using here intramuscular iron, please stop it from today onwards. And for postpartum, 100 milligram iron and 500 milligram microgram of folic acid for 6 months. Now, how do you find out the response? 1 gram per deciliter hemoglobin increase after 2 weeks of oral iron therapy was an accurate predictor of subsequent hemoglobin response at 6 to 8 weeks. What does that mean? You are giving oral iron, hemoglobin does not rise by 1 gram per deciliter after 2 weeks of oral iron. Please don't change over to some other oral iron tablet or liquid or capsule or something. Straightway go for intravenous iron. Please remember my words. Number 2, when you give iron prescription to your patient, how do you find out whether she is taking it religiously or not? Color of the stool. You know, today patients are very smart. You have prescribed it. She has bought it. She has taken the first capsule or tablet or liquid or whatever. She has noticed one thing, that her color of the stool has changed to black. But she has not liked the taste of the iron that you have prescribed. So she takes it for a day or two and then either keeps it, gives it to her daughter or to some neighbor or relative or someone. So when she comes after 2 weeks, 3 weeks, 4 weeks, whenever you called her and you ask her, stool ka color kya hai, like a CBI officer, she will tell you it is black colored, and you feel you have done a great job of prescribing iron. She is not taking it. Majority of the patients this happens. I spent my 34 years in teaching hospital at Mumbai. Patient comes, we examine, she goes to the pharmacy, she gets 15 days of iron, calcium, everything. And same thing happens what I told you just now. She doesn't take it. And you expect this hemoglobin to improve? Definitely not. What I feel is that, do hemoglobin after 2 weeks. If you are given oral iron, if the hemoglobin is not risen by 1 gram per deciliter, IV iron. And I'll tell you the best way, I3, I'll come to that. We all know about the challenges of oral iron, the side effects, poor absorption, non-adherence, very important. Non-adherence, more than 75% of our patients, non-adherence. Therefore, parenteral iron seems to be an attractive option for management of IDA. To summarize oral iron, I have not finished my talk. Oral iron supplementation is the first line of treatment during pregnancy. GI side effects can lead to suboptimal patient adherence. Therefore, parenteral iron seems to be an attractive option. So what are the indications for parenteral iron? Poor tolerance, very, very, very common. How many of you have felt that whenever you take iron, you have a bad taste in the mouth? I think 100% of us, all of us. And it's not that you have to take it for 7 days or something. When somebody tells you that this you have to take for 180 days during pregnancy and 180 days after the pregnancy is over, impossible. Poor absorption, non-compliant patient, very common in India. Women with moderate to severe anemia near term, patient on recombinant erythropoietin. You must keep contraindications in mind: history of anaphylactic reaction, non-rapid restoration of iron stores, active infection. So, when you want to give intravenous iron, stop oral iron for 24 hours at least. You finished with total dose of intravenous iron, you can start it after 1 week, or you need not start it as per the Ministry of Health and Family Welfare. It is all left to you. Most important thing when you want to give intravenous iron is that your diagnosis of iron deficiency anemia has to be 100%. Please remember this. Iron deficiency anemia, confirm the diagnosis. Then supervision and management of anaphylaxis. I3 doesn't require sensitivity test. Contraindications to be kept in mind. And stop oral iron when you want to give IV. Confirm the diagnosis of IDA. Taking you back to your MBBS days, how do you calculate the total iron dose for that woman she comes to you? 2.4 multiplied by deficit. Suppose she is 9 grams, you want to bring it to 11. I told you minimum normal is 11, please, not 10. So there is a deficit of 2 grams. So 2.4 multiplied by 2 is 4.8. Multiplied by her weight, pre-pregnancy. How many of us knows about pre-pregnancy weight? No one. So when she comes to you, whatever is the weight, take that into consideration in kg. Suppose it is 50 kg. 2.4 multiplied by 2, 4.8 multiplied by 50 comes to 240. Okay? Plus, when we were students, we were told for replenishment of iron stores, you have to give 500 milligram. Now it is 1000 milligram. So a woman who has 9 grams hemoglobin, you want to bring it to 11, you will give her 1240 milligram of iron. Am I right? Suppose she is 7 grams, borderline, severe and moderate. You want to bring it to 11. Now you have options of using different types of intravenous iron. The first, second, third generation. First generation was iron dextran. When we were residents, only iron dextran was available. Interferon injection, black. I don't know how many of you have used. Some of the seniors sitting here, they have used it. Interferon injection, deep intramuscularly, upper and outer quadrant. Now let me tell you honestly, you call this patient after 2 weeks, she would come within couple of days and you feel as if she has fractured her leg or something when she is walking to you. Severe osteoarthritis. Severe osteoarthritis. We had no options in those days. Majority of us used to give this. Iron sorbitol citric acid complex was there, but that was in those days used by GPs. So we used to stop it. Very simple. Then came second generation iron sucrose. Iron sucrose. Everybody shifted to iron sucrose. There were maternal deaths. They are reported. They are published. Reported deaths of iron sucrose. There are many which are not reported. Iron sucrose. So you had to give test dose. Then only you could give parenterally. And came the third generation, what we use now, the ferric carboxymaltose, FCM. When I was at KEM hospital, we started to use this FCM. We used to do hemoglobin 24 hours after the delivery, irrespective of route of delivery. If it was less than 10, I'm sorry, again we used to use that time, 10 only. We used to give 1000 milligram FCM before sending her home. 1000 milligram FCM. She would pay for it. Because the KEM hospital, the municipal corporation hospital, they could not afford. But we made them pay half the amount because the patients were poor. And we gave thousands of this FCM. Because no test dose is required, less chances of complications, but the deaths were reported. Anaphylactic reactions were reported. But we had no choice at that time. Better than iron dextran, better than iron sucrose, so FCM was used. And now has come the third generation, the second salt, that is I3 injection, iron isomaltoside. No test dose required, half the cost of FCM, very important for Indian people. No deaths reported till today, very few, if at all, side effects. And you can give up to 1500 milligram in one shot. FCM we could give only 1000 max. So a woman who has to be given 1240 or 1480, you had to call her twice. Here you can give only in one shot maximum iron that has to be given, the total dose of iron 1480, you can give up to 1500, okay? Half the cost. Again, it's a strong complex, both FCM as well as injection I3. I am showing you this slide to tell you that please do not use intramuscular iron. That is the only reason I am showing you this slide. Now, you have hemoglobin more than 10 but less than 11, mild anemia, ferritin less than 100 nanogram per milliliter, total dose anywhere around 1300 plus, start with oral iron, mild anemia. Give it for 4 to 6 weeks. If the hemoglobin, I am saying 4 minimum up to 6 weeks, hemoglobin goes up by 2 grams per deciliter, continue oral iron. If not, straightway gone to intravenous. Very simple. And if the hemoglobin is less than 10, do not give oral iron. Straightway give her intravenous iron. I'll tell you why. We can't rely on our patients to take oral iron. You're given 1500 milligram in one shot. She has come once only to you. She goes. She has gone. One shot and you're given full iron required for the pregnancy. That's it. Something very simple. Now, I don't know how many of you have picked up this, that each iron complex has a carbohydrate moiety. Iron dextran at dextran, iron sucrose at sucrose, ferric carboxy maltose had maltose, and iron isomaltoside has isomaltoside as carbohydrate moiety in it. So what is the importance of this carbohydrate shell in parental iron? Every parental iron is complex with carbohydrate moiety, which holds the iron till iron complex reaches liver and spleen. It holds it, it binds it. Stronger the complex, safer is the parental iron because it will release less labile iron. What is labile iron and how is it harmful? Labile irons are free iron released from the iron complex when given intravenously after administration. Since these are free irons, they are responsible for effects like hypotension during intravenous infusion, hypersensitivity, reaction, oxidative stress, cytotoxicity, etc. Free iron that is released when you give it intravenously. Okay? Labile iron potential is least with injection I3 compared to any other iron preparation for parenteral use. Look at this. Iron sucrose has maximum chances of releasing labile irons. FCM has moderate chances, and injection I3 in the middle has least chances of liberation of labile iron. Now look at the one which is highlighted in blue line. The maximum single dose of iron sucrose that you can give is 200 milligram. If you give more than that and patient has some problem, serious problem obviously, you are gone. Okay? I have seen people giving 400 milligram iron sucrose. God save those patients. FCM maximum you can give in one shot is 1000 milligram, whereas injection I3 you can give up to 1500 milligram. It is approved by US FDA and we have in India DCGI approval. Now what is the mechanism of this I3? Parenteral iron isomaltoside is absorbed by reticuloendothelial cells of liver and spleen, and the splitting of this iron complex occurs in liver and spleen by reticuloendothelial cells themselves. The free iron binds to protein and forms ferritin, which replenishes the iron stores. Now, few slides on iron sucrose versus I3 and FCM versus I3. It is not that I am thoroughly impressed by injection I3 or something that I am here to talk to you, but there is an evidence-based medicine which I am going to show you now. I have told you, you can give in one shot the maximum amount of iron required intravenously with injection I3, whereas you do call iron sucrose patient many times. Today, iron sucrose is used by GPs. I don't know whether you know that. Why? Because the patient has to come 5, 6, 7 times. Every time she is charged for intravenous, for lying down, for monitoring, plus iron sucrose. The overall cost that she gives to her GP is more than injection I3. Overall, number of times she has to come, go, and all those things different. Look at the hemoglobin increase from baseline, about 1.5 grams after 2 weeks with iron isomaltoside, whereas it was 1.2 grams. Proportion of responders with hemoglobin increase more than 2 grams per deciliter was 32% after 2 weeks with iron isomaltoside, whereas it was 21% with iron sucrose. Percentage of patients with increase in hemoglobin more than 2 grams per deciliter was 68.5% with iron isomaltoside I3. It was around 52%. And the median time for rise in hemoglobin by 2 grams per deciliter was 26 days for I3, whereas it was 37 days for iron sucrose. So iron sucrose can be given maximum 200 milligram, not more than 3 times per week, and the doses must be at least 24 hours apart, whereas the intravenous iron isomaltoside can be given 20 milligram per kg for more than 1000 milligram up to 1500 milligram in single visit. There are now many studies which are published internationally. Remember this, internationally. And this is from International Journal of Life Science, Biotechnology and Pharma Research, September 2023, comparative study of efficacy safety of isomaltoside versus iron sucrose in iron deficiency anemia of pregnancy. What is the conclusion of this paper? I3 should be used as a first line treatment to bring about a revolution in the management of iron deficiency anemia of pregnancy, as it is safe and more efficacious than iron sucrose. Now coming to the one that you have been using, FCM. And I told you, even we were using at KEM hospital FCM because I3 was not available at that time. But remember this, whatever I am saying, the one in green at the top is the place where it is published. January 2022, Bone. Drug safety, there is a higher risk of hypophosphatemia with FCM. How many of you know that? Please raise hands. She was there in my last talk, by the way. At least she remembers that much. FCM, even in one sitting, causes raised fibroblast growth factor, which leads to reduced phosphorus level, reduced vitamin D level, reduced calcium absorption, and all these things will lead to hypophosphatemia. How many of those MRs who come to you to talk to you about FCM tell you that there is a higher incidence of hypophosphatemia with ferric carboxymaltose? Even a single shot. No one. Even I didn't know. Honestly. I told you, thousands of ampoules of FCM, but we had no option at that time. Now we have option. Better option. JAMA 2020, 10 times higher incidence of hypophosphatemia with FCM compared to I3. I3 7.9%, whereas FCM 75%. One more study, 8% with I3, whereas it was 73.7% with FCM, hypophosphatemia. Journal of Nephrology and Hypertension, 2012, no change in vitamin D and calcium homeostasis with iron I3. Iron isomaltoside versus FCM and indirect treatment comparison, ITC. Now you read that thing in red, I don't know whether you can read it, but I want you to read the last line at the bottom, you can't read well. Journal of Medical Economics. Journal of Medical Economics. You will say we don't read gynec journals, obstetric journals. Why you are talking about economic journal? But this is from not our country. Please remember this. This was published in 2020 from UK. The objective of this paper was to use indirect treatment comparison finding to evaluate the cost effectiveness of I3 versus FCM. The last two lines in block. Total cost of infusion with in pounds for FCM and in red for I3. There was so much difference. Please remember this. Even in UK. In India, if you buy FCM from a reputed pharmaceutical company, it is 3,400. I am talking about reputed. 150 pharmaceutical companies are manufacturing FCM. Some of them will come to you saying that I'll give you in 700, I'll give you in 1,000 also. Please do not go for inferior quality FCM. It will not give you desired results. You don't want to buy something just because it is cheap and it's not going to be effective for the patient. Please remember this. The cost of I3 is 1,700 for same 500 milligram. Half the cost of good quality intravenous iron. Remember this, okay? Good quality. I am making it again clear to you. How iron isomaltoside is superior to FCM? Hemisphere 2023 conclusion. Interim analysis of this particular study, the safety and efficacy comparison trial has noted no statistically significant difference between two parenteral preparations. But isomaltoside offers safety and efficacy at a low cost. We already talked about this, less labile iron deficiency correction in one visit. And it is not only used in obstetric and gynec, but also in chronic renal diseases, inflammatory bowel disease, gastroenterology, oncology, cardiology, perioperative care. Coming to during pregnancy, again, from India, people have not published. There are 40,000 reports already received. They're going to be published from Karnataka, Bellary. 40,000. No deaths. Hardly any anaphylactic reaction. Once it is published, at least we will have something to rely on. But till that time, there are all these publications from abroad for injection isomaltoside. We all know that all three, iron, sucrose, FCM, and I3 are all category B drugs. Risk of serious or severe hypersensitivity reaction was lower with I3 relative to FCM and iron sucrose both. All you can read on the top from where I got this, International Journal of Transfusion Medicine. Conclusion, these results support convenience, safety and efficacy of single high dose up to 1500 milligram infusion of I3 for iron deficiency anemia. Now coming to this postpartum, why I have brought this postpartum is, as such our patients don't come back to you if the baby is not well, she will not come back to you unless she has to get the sutures removed or something. Do we ever ask our patient who comes for follow-up after delivery, irrespective of route again, whether she experiences fatigue when she starts working? Because I had worked in Municipal Corporation Hospital, we used to have poor patients coming to us. They can't afford to take 3 months rest at home and all that. They have to start working as early as possible. In private practice, we have patients who has a cook at home, who has servants at home, and there are people who look after, the mother comes down to look after her. So there's a different situation altogether. But if you look at a poor patient, even middle class patient, you ask whether she feels fatigued when she starts working the way she used to work before she got pregnant. That will give a clear-cut idea that probably she has got iron deficiency anemia, which is not corrected. Iron isomaltoside in postpartum fatigue. If anyone is interested, read this Journal of Maternal Fetal Neonatal Medicine, 2019. What is the conclusion? A single dose of I3 is associated with a statistically significant and clinically relevant reduction in aggregated physical fatigue within 3 months after delivery. This is something very important that we have to inculcate in our practice. And Hong Kong Journal of Gynecology and Obstetric Midwife 2022, and isomaltoside for treatment of IDA with postpartum hemorrhage, PPH patients. 4.4 grams per deciliter rise in hemoglobin in 6 weeks and increase by 151 microgram per liter of ferritin level in 6 weeks. The rapid sustained improvement in hemoglobin and ferritin level by iron isomaltoside. What about the milk? Good paper in International Journal of Gynecology and Obstetrics that iron isomaltoside increases the iron content in maternal milk by almost 2 folds. 2 folds. Now how do you use it? How exactly do you use? Iron isomaltoside should be infused undiluted or diluted in normal saline. Don't use undiluted. I am giving you instruction, don't use undiluted. Okay, that is one thing. If you want to give up to 1000 milligram I3, dilute it to 100 milliliter of saline, 100 milliliter. But if it is more than 1000, up to 1500 milligram, 250 milliliter of normal saline you will dilute in. And you can't say कि मेरे को किधर जाना है, I'll come back after half an hour. So see that it continues for half an hour when you are given 1000 milligram. No, you have to finish it in the time interval that is given to you by the company that has manufactured this product. Less than 1000 milligram, 15 minutes. 1000 to 1500 milligram, 30 minutes. All the complications, the side effects that have come up, they're all because people do not strictly adhere to these instructions. Honestly. Do not put it in refrigerator. 500 milligram ampule that comes in 5 milliliter, do not put it in refrigerator. Hemoglobin more than 10, less than 11. Patients weight less than 50, 500 milligram. Patients weight between 50 to 71,000. If it is more than 71,500 milligram. Last few slides. Total dose per week should not exceed 20 milligram of iron per kg body weight. Total dose per week. Single infusion also should not exceed 20 milligram of iron per kg body weight. Okay, I hope it is clear. In case you have to give it more, give it after 1 week. Give it after 1 week. Okay? Right. To evaluate effect of intravenous iron treatment, hemoglobin level should be reassessed no earlier than 4 weeks post final iron isomaltoside. I am not talking about oral iron. I3 injection. You are given total dose. Up to 1005 milligram, any patient, it will be a total dose. Call her after 1 month for repeat hemoglobin. Okay? Not earlier. Should be infused, undiluted or diluted. I already talked to you. For stability region I3 should not be diluted to concentration less than 1 milligram of iron per milliliter. Please remember this. Never put it in 500 cc saline. Up to 1100 cc, 1000 to 1500 milligram, 250 cc. Don't put it in the usual IV, one IV saline. You all know when to give blood less than 7. We will not go into details. We all know the side effects of blood. But there's a nice paper, Fox sang in 2017, iron isomaltoside in postpartum anemia. What is the conclusion of this paper? The study shows that intravenous iron could be an attractive alternative to RBC infusion in severe postpartum anemia. We are in Mumbai, Delhi, Kolkata, Lucknow, Madras. Getting blood is never an issue. We never feel what is the importance of getting blood. You go to periphery, smaller villages, there is no blood bank around. By the time the relative goes and gets blood, if her hemoglobin is less than 7, please give injection I3 as an alternative. I am not saying this, there is a publication. If you have time, please read it. This is something very important. The time that is gone, by the time actually RBCs come, is gone. You can give her at least 1500 milligram, or if not at least 1000 milligram of I3 intravenously in 100 cc of saline. Okay? Right. Summary. Low immunologic potential. Low potential to release labile iron doesn't appear to be associated with clinically significant hypophosphatemia. No test dose required. Only intravenous iron that can be given up to 1500 milligram. Less overall treatment cost compared to FCM and even iron sucrose. Higher and faster hemoglobin rise compared to any parenteral iron available today. In clinical and observational studies, no acute anaphylaxis, delayed allergic reaction, no mortality as yet. And obviously we all know category B, safe.